short delay. Okay, so kita punya topik for this morning is sekejap. Hang on, masih ada technical glitch sekejap. Dia tak nak bergerak. I'll share again. Okay, can you see my slide now? Hello? Okay. So this morning, introduction to clinical genetics. So I think this is quite an important topic for you to pay attention to, because you won't be having any similar lectures or teaching related specifically to clinical genetics per se in your next few years of posting. Okay. So the key learning points, first, we like to understand, I want you to understand what is the different type of genetic abnormalities. And then at the same times, you need to understand what are the different type of genetic diseases. For example, birth defects. And understanding in the different mode of inheritance. And you need to be well aware of how do we draw a family pedigree, and what do we mean by genetic counselings, and what is a clinical genetic services. Okay, so for a start, we revise, we go to revisions of cell biology. Okay, yeah. So if your human genome, you have heard so much about human genome. If you open your journals, you read in the papers, whether it is an academic papers or the general papers, there is always a mention on human genome. Simply, it is just a complete set of nucleic acid sequences, which is encoded as DNA, and it is present in your nuclear chromosomes. So, okay, your nuclear chromosomes, which is present in your nucleus. Okay, so there are 23 chromosomes, and also in your mitochondrial DNA. So your in your cells, if you remember correctly, there is mitochondrial suborganelles, and within it there are mitochondrial genomes, and that encodes for about 13 protein and non-protein products such as transfer RNA and ribosomal RNAs, which is important for regulations of your DNA transcriptions and other functions. Okay, so this is your cell, as what I have mentioned earlier, your nucleus, and within it there is your chromosomes, and your gene is located on your chromosomes. Okay, and this is your chromosome. So there are 23 pair, including your sex chromosomes. So and these chromosomes again contain the gene. There are around 30,000 genes, which is known to be functioning. But this 30,000 gene only form a small component of your human chromosomes. Okay, it is probably just about 10% or less than your human chromosome. The rest are things that we don't really understand. Okay, and if you look at your chromosome morphology, you got your P arms and your Q arms. Okay, your P arms and Q arms is joined in the center by a constriction known as centromere. Okay, and at the end, at the terminal end of your P arms and your Q arms is an area that you call telomere. Okay, right. And this telomere is contain highly repetitive gene, sequence of gene. Okay. So based on the locations of your centromere, you can divide your chromosome into three different structures: metacentric, submetacentric, and acrocentric. So metacentric, if the centromere is exactly in the middle. submetacentric if the centromere is at near the tips, is in between the tip and the centromere. Okay, right. And whereas acrocentric is when the centromere is really near to the tips of your P arms. Okay, right. So this is what we call as acrocentric. So acrocentric, the P arm is really, really small, really, really short. So based on the location of the centromere, as well as the size of the chromosomes and the bending pattern that we see when you stain the chromosomes, you can recognize whether this is chromosome 1, 2, or 3. In fact, it is given the name chromosome 1, chromosome 2, chromosome 3 based on these three characteristics. Okay, so the first three is the biggest chromosomes in which the centromere is located in the center, right? Almost in the is metacentric, so they are generally metacentric chromosomes. So if you go towards the end, the chromosomes are smaller. Okay, right, and uh, and you can see that some of the chromosome are acrocentric. So chromosome 13, 14, 15, 21, 22, they are all acrocentric chromosomes. Okay. Actually, one chromosome is actually formed by a DNA deoxyribonucleic chain, if you remember, which is present as a double helix, a coil, and then this structure is actually coiled and looped multiple times. Okay, so here from one long double helix structures, it is called around histone, like this, and this coil of DNA around the histone is further coiled further, right? And subsequently is looped and finally is coiled again. So to form your compact chromosomal structures that you see in your karyotype earlier. Okay. So in fact, somebody says that if you unloop all these coil chromosome, it is very, very long. So the whole chromosome, you can actually, it can sort of, it's as long as a circumference of your football field. Okay, right. And this is the structure of your chromosome, your DNA helix. Okay, so deoxyribonucleic acid, which is bounded together by a hydrogen bonds, and this bonding resulted from sort of attachment of your two bases. You know that the bases are paired according to the types: thymine, adenosine, thymine, adenine, guanine, cytosines. Okay, right. And these three bases is actually a code. So you call it codon. So each code, each three structures will code for an amino acids. Okay, right. And so this is your gene actually is structures like this. Okay, this is your standard structures of gene. Okay, it has exon, intron. Exon is the one that is finally transcribed into that form into proteins. And in front you got these various regulation centers, your untranslated region, your promoter region, and at the end also there is untranslated regions. Okay, and various regulators. Okay, so this whole set is a gene. One gene can to be transcribed into at least about three different protein. It's not just one gene, one protein, but into about three different protein. This is because of the presence of different splice site. Okay, so just a revision: your DNA, your transcription into RNA, and then is exported into your endoplasmic reticulum, where it is transcribed into your when it is processed subsequently into protein at the Golgi apparatus. Okay, right. And another location where you can find your genome, human genome, is in the mitochondrial. Okay, so if you remember correctly, your mitochondrial is two wall structures, organelle, and your mitochondrial, your genome is the mitochondrial genome is located inside your mitochondrial. So mitochondrial genome is a rings-like structures, as shown here. Okay, right. Okay. Then what is genomic variance? Okay, this is another terminology that you have to understand. Okay, so you see we are not the same. All humans are different. Although the majority of our genes are the same, from like my gene is almost as the same as yours, but I have some variation that make me different from you. Okay, uh, and we know that there are around 4 to 5 different genomic variants in an individual genomes. Okay, and this variation is unique to me, and your variation is unique to you. Okay, but among my relative, there might be a lot of similarity with regards to this variation. Okay, and among these variants, some are pathogenic, some are non-pathogenic. Okay, pathogenic means that this variation can lead to diseases depending on uh, the type of variations. Okay, and the locations. Okay, and the genes that is affected. Okay, right. Uh, so how this genomic variant influence the risk for specific disease. Okay, we're going to sort of talk more about it later in our slides. Okay, right. So just again to highlight what is variation. Person one has a, sequence like this, DNA sequence like this. Person two has a DNA sequence like this. So at the cytosine here, the first person has cytosines as the base, but the second person has thymine as the basis. So whether it is pathogenic or not, it depends on the function of this gene. If it is on the gene, the function, and again whether it change the structure of the protein that it is supposed to be to code. Okay, and various other factors that determine the pathogenicity. Okay, some variation will not cause disease, but in the presence of other environmental factors, that particular persons are more at risk of developing disease compared to a person who does not have variation. And sometimes variation is good. Okay, if you have that kind of variation, you might be more resistant to a disease. Okay, right. So this is just about genomic variation. Okay. Again, multiple individual with sort of different variations. Okay, right, maybe pathogenic and not pathogenic. Okay, right. Now let's look at the type of genetic abnormalities. Okay, um okay, so what is genetic abnormalities? It is a disease. Sorry, let's just talk about genetic disorders. Okay, a genetic, when you talk about genetic disorder, it is a disease caused by a change in DNA in whole or in part away from the normal. That's it. That is a genetic disorders. Okay, so what sort of genetic abnormalities can lead to genetic disorders? Okay, one is your chromosomal aberration. So chromosomal aberration is when part or whole of your chromosomes are damaged, whether there is a change in the number or change in the structure of the chromosomes. Okay. Uh, then it can also the genetic disorders, genetic abnormalities that lead to genetic disorders can also be due to mutation in the gene. whether it is present in your nuclear genomes or in your mitochondrial genome. Okay, so a gene mutation can be a single gene disorders, meaning that only one gene is affected. Okay, a multiple gene disorders, or different defects in different gene can result in that particular disease. Okay, or it can be a combination of gene mutation and environmental factors. So we call it multifactorial inheritance. Okay, I just put birth defect here. Birth defect is not a type of genetic abnormalities, but it is a disorders that is frequently due to genetic abnormalities. It's a genetic disorders, although some of it are not directly due to genetic effect, it may be due to teratogens, but I like to classify it under genetic disorders, okay? And in fact, most people would classify it under this genetic disorders. It's mostly discussed under genetic disorders. Okay, let's look at chromosomal aberration. So, okay, so chromosomal aberration, okay, just hang on. Just forget that slide first. Okay, when there is mutation, it's a mutation as well, but it involves large part of the chromosomes. Normally, it is more than 4 megabase, and it is typically visible under light microscopy. Okay, so the abnormalities can be a change, as I mentioned earlier, numericals, or it can be structural. Okay, let's have a look at the example. Okay, so this is numerical abnormalities, right? You see, instead of having 47 chromosomes, so this karyotype shows that the individual has 48 chromosome, because chromosome 21 has there is three chromosome 21s, okay? So this is what diagnosis? What condition does it?
Down syndrome.
Okay, yeah, good. Okay, right. Okay, and this, how many chromosome is there? 23 times 3 kan? So 69 chromosome. Okay, so this is another type of chromosomal abnormalities where there is change in the number of chromosomes. So the change is called polyploidy because it is multiplication of your haploid number. Your haploid number is 23 kan? So this is 69. Okay, in contrast to previously, this is called aneuploidy because this is not multiplication of your haploid numbers. Okay, right. And then we got changes due to structural abnormalities. Okay, sorry, here is another example of numerical abnormalities. So how many chromosomes are there altogether? Ya, berapa? Ada berapa kromosom? Should I call Alia? Alia bukan Alia the first person Alia, or is it the same person, Alia Najwa and Alia? Sorry? 45. Alia kenapa tak jawab?
Alia me or Alia Najwa, Doktor?
Alia you the first one.
Okay. Oh, sorry.
Kalau I will call you your name one by one.
Okay.
So ada berapa kromosom?
45.
Okay, 45. Okay. So that is so normally patutnya ada berapa? So by right ada berapa kromosom?
46.
56. Okay, so this is numerical abnormalities kan? Okay, now we have a look at structural abnormalities. Okay, so deletion, this is just an example. Okay, so what in deletion, part of the chromosome is being deleted out for some reason. So in this example, this chromosome, the second pair is deleted. So the second pair of chromosome is shorter than the first pair. In the picture here, so you see in the picture here, yang ni is still attached at the centromere kan? Yang ni dah separated. This is because this is a different phase of the cell divisions. So, right. Okay, and then insertion, if there is an additional chromosomal material being inserted into the chromosome. In this case, part of the first chromosome is inserted into the second chromosome, the green chromosome. So, resulting in one pair of the green chromosome to be longer. Okay, so this is insertion. Okay, inversion is when the structure of the chromosome is being inverted upside down. Okay, so if it is involving, not involving your centromere, so you call it pericentric. If it is involving your centromere, this is paracentric inversion. It can happen both ways. Okay, isochromosome, if when the upper arms and the lower arms of the chromosomes are the same structures. Okay, how can that happen? Well, that happened again during your meiotic divisions. Okay, so what happened during your meiosis, your cell divides, kan? So initially, say A is the chromosome, say chromosome 1, and then during cell division it is separated into two daughter chromosome, isn't it? B is daughter chromosome of A. Okay, so and this is because initially the A chromosome duplicate, isn't it? Duplicate to form duplicate structures, then it is separated vertically, okay, into two daughter cells. But in abnormal situation, so chromosome A which duplicate, it is separated separated vertically. Now they're separated longitudinally, so resulting in two daughter cells with isochromosomes. Okay, the first daughter, the purple one, has two chromosome, two P arms. Okay, the second daughter has two Q arms, have both Q arms. Okay, so you call this isochromosomes. And then you have ring chromosomes when the terminal end of the chromosomes can attach to each other to form a ring. Okay, so this is ring chromosomes. Okay, and you also got a fragile sites. These fragile sites just so when you look under microscope, you see that the terminal part of the chromosome appeared to be sort of detached and only attached by a string-like structures. Okay, so you call this fragile sites. Okay, and then you have translocation. Translocation happen two ways. How it can happen? This is the first method. So one part of the chromosome goes to another chromosome, and this part of the green chromosome goes to the purple chromosome. So they exchange the chromosomal material in between two chromosomes. So this is translocation. This is reciprocal translocation. Reciprocal, you give to each other. Okay, and then there is Robertsonian translocation, and this normally happen in between two acrocentric chromosome. Tadi kita dah talk about acrocentric chromosome kan, so two acrocentric chromosomes. So in this case, the Q arms of chromosome, green chromosome, become attached to the Q arms of the purple chromosomes. Okay, whereas the P arms of the purple chromosome and P arms of the green chromosome disappears because they are too small. Okay, so at the end of the day, you got a derivative chromosomes formed by the Q arms of the green chromosome and the Q arm of the purple chromosome. And at the end of the day, how many chromosomes would be there? Total. So because of this, there would be only 45 chromosomes kan? Instead of 46. Okay. Okay, now you got duplication. Duplication means that a part of this chromosome is duplicated. So here, it results in a longer, one pair of the chromosome, this chromosome is longer, okay, because there is duplication of the DNA, okay. So all these are sort of an error that occurs during cell divisions, okay. It is not supposed to happen, but it happened. Okay. Then what is gene mutation? I think there simply means that there is a change in the gene sequence. It's almost the same as chromosomal aberration, except that chromosomal aberration is bigger, and you can see it under like microscopy in contrast to your gene mutation here. So I just want to say that you have this point mutation or length mutation. Point mutation is just alteration in the genetic code without gain or loss of genetic material, whereas length mutation is when there is gain or loss of material. So at the end of the day, there is change in the length of the DNA, as shown in the example here. Okay, so we'll just keep this one. Okay, let me we just keep this one. Okay. I like to go to the other type of genetic abnormalities. So can you see the slides? Okay. So I want to talk about uniparental disomy, okay? So you look at these two child. Are they the same or they are different? Do they look the same or are they different? Nak suruh I panggil lagi kah? Okay, now let me call upon Amelia Tan. Okay, Amelia, can you answer? We'll wait for Amelia until she answer the question, baru kita continue with the lectures.
Doktor, Amelia dia pergi toilet
Can you call her? Dia kat mana? Toilet kat mana?
kat rumah dia.
How do you know that she is in the toilet?
She WhatsApp me.
Sorry?
Dia WhatsApp tadi, dia cakap dia sakit perut.
Okay, then we go to the next student. Anis Atika.
So I guess it's different because the face of the boys doesn't look alike.
Okay, yes, correct. They looks different kan. Yang satu lagi tu obese kan. Yang seorang lagi tak obese kan. Okay, and the face is also different. The first child, the mouth looks the mouth looks small. The second child, he has a wide mouth. Okay, and of course lah, macam dari jauh tu is difficult to clearly see the difference. But you see that the eyes is also different. Okay, and the apa tu
The hair color also different, I guess.
sorry.
I think the hair color also different because the first one is maybe
Tak apa
brown.
hair colour tu sebab yalah orang tu both are Caucasians, tapi some Caucasian memang they have fair hair kan. Tapi and you look at the posture is also different. Okay, tak apa, we'll just have a see. So the first child, this child has Angelman syndromes and this child has Prader-Willi syndromes, but you see that both of them, the chromosomal abnormalities is located at the same region, 15q11 to q13. Okay, 15q11 to q13. Okay, but why are they different? That is interesting, isn't it? Because you expect that if the chromosomal defect is located at the same area, they should look the same kan? But it is not. And this is due to the phenomenon known as uniparental disomy. Okay, so when the chromosome of this child are further studied, it is realized that the chromosome 15 15 tadi, 15q11 to q13 tadi, of this child, both comes from the father, originated from the father. Whereas in this child who has Prader-Willi syndrome, both chromosome 15q11 to 13 comes from the mother. So, I mean, if you wonder how do we know it's from the father, how do we know it's the father? Well, that can be easily investigated by various laboratory techniques. There are ways to determine the origins of the chromosomes. Okay, right. Before, to understand how does that happen, you need to remember the meiosis. Okay, what happened during meiosis? Because what happened, uniparental disomy is most likely caused by an error during meiosis. Okay, right. So if you remember your cell division correctly, you got this initially in the resting period, your chromosome is in these structures very long. It's just like a hair, okay, a clump of hair, okay. But before the start of cell division, they started to coil and then shortens to become these shapes, okay, and then they duplicates from haploid structures. It become diploid structures, okay. Sorry, from diploid duplicates, okay, and after that they rearrange themselves, okay, in this line and then separated, okay, into two daughter cells, okay, right. And again, maybe this is just for your remembrance. This is again what happened during meiotic divisions, okay. So during meiosis, this is the cells before divisions, okay. So during meiosis 1, they divide into two daughter cells, okay, and but each daughter cell at this point is still diploid in structures, and during meiosis 2, it further divide into two daughter cells, which are haploid, okay. And at the end of the day, you got four daughter cells, okay, all of which are haploid structures, okay. But a non-disjunction, it means that an error in the separations of your chromosomes, okay. It can occur in meiosis 1 or meiosis 2, but that results in if the error occurs in meiosis 1, what happens is that you can have daughter cells which are trisomy or monosomy, like this case, okay. If it occurs in meiosis 2, you can have four daughter cells, of which two are normal, but one will have trisomy and the other one will be monosomy. So non-disjunction, whether in meiosis 1 or meiosis 2, will result in daughter cells with which are monosomy or trisomy, okay, right. So let's have a look now why how UPD can occur. So there are various theories, okay. So you look at the first example. This is normal situation. Say that the white gamete is ovum and the black gamete is sperm, okay. So during fertilization, zygotes is formed containing a diploid structures, diploid DNA, with both mother and father's chromosome, okay, right. But if, for example, there is meiotic non-disjunctions, so what happens is that it can result in a daughter cells containing a diploid structure instead of haploid gamete. So say this is happen in the mother, okay. So one of the daughter cell can contain diploid gamete instead of haploid gamete. So the resulting zygotes following fertilization is trisomy zygotes. And during and further cell divisions during mitosis. So zygote is post fertilization, okay. So one zygote it need to continue to multiply to finally form fetus. okay, with different structures and organs, okay, right. During the first cell divisions, there is a further non-disjunction resulting in two different types of cells, of daughter cells, one with UPD, one without UPD. Okay, right. So this is you call it as trisomic zygote rescue. Okay, so an attempt to rescue the zygotes by non-disjunction. Okay, at this point of time. Okay, right. Another way on how UPD can occur if there is non-disjunction of both the mother's ovum and father's sperm. Father's sperm do not contain any gametes, and the mother's ovum contain two gametes instead. So fertilization, there will be two gametes, but both come with chromosome that comes from the mother. Okay, right. Or there might be compensatory UPD. Mother gamete is normal, but father gamete, because of non-disjunction, there is no gamete inside it. Okay, so this will result during fertilization. It will result in monosomy gametes, monosomy zygotes. But to correct the problem, the body duplicate these chromosomes, resulting in two chromosomes that comes from one parent. So these are several theory on how UPD can occur. We will not talk about this, the last possibility, because this is a bit complicated. Okay. Okay, so that is uniparental disomy. Now we'll talk about mitochondrial disorders. Okay. Mitochondrial disorders are disorders due to defect of the respiratory chain function. Okay. So you remember your mitochondrial gain. Okay, so this is your nucleus, this is your endoplasmic reticulum. So mitochondrial contain one of the most important function of mitochondrial is to produce energy in the form of ATP. So if there is a problem in this respiratory function, you call it mitochondrial disorders. Okay. Okay, but apart from producing energy, mitochondria also contain various key metabolic process, your oxidation of free fatty acid, your Krebs cycle, ketone productions, and things like heme productions. Okay. Okay. So again, a cartoon drawings of your mitochondrial structures. So within the mitochondrial, inner wall of the mitochondrial is is where your oxidative phosphorylative system is located. This is the factory that produce ATP. Okay, and within the mitochondrial also you got your mitochondrial genome, which I didn't draw inside here, and other key processes. Okay, so this is your oxidative phosphorylative complexes, also known as respiratory chain, which is in which the most important function is to produce ATP. Okay, your respiratory chain is assembled by proteins that is coded by your mitochondrial gene as well as your nuclear genomes. Okay, so a disease in the nuclear genome can also cause respiratory mitochondrial disorders, not just a mutation in the mitochondrial genes, but also mutation in the nuclear genome. Okay. Okay. During fertilization between ovum and sperms, the resulting zygote contain basically mitochondrial that come from the mother, because the sperm contain only few mitochondrial and is sort of negligible. Okay, it doesn't contribute to the mitochondrial of the child, of the zygotes of the fetus. Okay, so right, so that's why okay, your mitochondrial inheritance is only inherited from the mother. If you look at this pedigree, you will see that the mother will transmit the disease to the child. okay, whether it is a boy or girl, mother to child, okay, but a father cannot transmit the disease to the children because his sperm contain only few mitochondrial and it is too little to contribute any disease, okay, too few. Then I would like to talk about another disorders known as multifactorial disorders or polygenic disorders. Earlier, I mentioned that people have genomic variations. Okay, some of the variations may not result in disease per se, but the presence of this variation may sort of make the patient susceptible to disease when exposed to certain environmental influences such as diet, sleep, stress, smoking. An example of diseases that can be classified in this group includes diabetes, cleft palate, SLE, okay, even neural tubes associated with folic acid deficiency, okay, that is associated with certain genetic variation. Okay. Okay, right. I just want to mention that. Okay, wait. Okay, never mind. We just forget about this. Okay, right. Now I want to go to another topic known as dysmorphic or dysmorphology. Okay. If the term dysmorphic means disordered, badness, or morph. Okay. Before that, I want to ask somebody. Okay. Badrul. Okay, Badrul, are you there?
Yes, doctor.
Hello?
Yes, doctor.
Okay, give me an example of a dysmorphic condition. Paling mudah, yang paling common.
Down syndrome boleh?
Down syndrome, boleh lah. Okay.
Trisomy 21.
Trisomy 21. So this is dysmorphic, okay? So Down syndrome is dysmorphic, isn't it? There is physical features that is different from other individuals of the same age, ethnic groups, that is beyond normal for age, ethnic origin, or unaffected relative, isn't it? So this is dysmorphic. The term dysmorphology was first coined in 1960s, okay? It simply means that this is a study of dysmorphic features, the study of the origin of these dysmorphic features and nomenclature of these dysmorphic features. So all this encompass the term dysmorphology, okay? Or it can also mean the study of human congenital defect and abnormalities of the body structures and the interpretation of these abnormalities. So this is dysmorphology, okay? Okay, I think, okay. Now you look at this father and daughter. Okay, what do you notice? Okay, I'll just ask, wait. Fadlan.
The
Okay, what do you see?
the eyes like ke bawah sikit, mata dia koyuk sikit.
Okay, correct. So you call it down slanting eyes. Okay, lagi?
Telinga dia.
Yeah, so what about the ear?
Macam disfigure macam like not
So,
normal.
so there is ear anomalies. Ear is, you call it anotia, okay? Partial anotia of the ears or malformed ears. You can say malformed ears. That is also correct, although not very specific. So he has malformed ears. And what you think is the child wearing on the head?
I'm not sure lah.
Anybody?
Device.
Hearing aids. Hearing aids.
That is hearing aid, correct. So it means that the child is also deaf. Okay. But and it's not just the child, isn't it? The father is also wearing hearing aids. So both of them are having hearing issues, requiring hearing aids. Okay. Right. What else do you see? The small jaw, isn't it? They have very small jaw. And if you look at the eyes carefully, mana I punya mouse hilang lah. Okay. You see that there is a notch there, isn't it? So this is eyelid coloboma, okay? And the father also has some depression here. So this is another feature. So anybody can, tapi dah ada tulis kat sini, this is Treacher-Collins syndromes, okay? Treacher-Collins syndromes. It's an autosomal dominant condition, okay? Right. Okay. Okay. Now, tadi dysmorphic features tadi kita dah talk about syndromes. What is syndromes? So it is a recognizable pattern of dysmorphic features. You see the father and daughter just now. So this pattern, the facial appearance that you see is seen in other people as well, and it is given a recognizable pattern. So you call these syndromes, okay? And we know that these abnormalities is caused by a common etiology, okay? So so it falls into the definition of syndromes, okay? Recognizable pattern of dysmorphic features caused by a common etiology, okay? Another example is Turner syndromes, okay? So a child with Turner syndrome, so the problem is there is only one X chromosome in a female, okay? So, and that gives rise to various phenotypes, okay? They are short, they have low anterior hairline, they have these characteristic facial features with flat nasal bridge, okay, epicanthid fold, okay, and classically they have this fold of the skin of the neck, giving rise to web neck, okay? And this is associated with congenital heart disease, particularly coarctation of the aorta, and the chest appeared to be like shirt-like. The nipple are widely spaced, and there is in the elbow elbow deformity. Also, if you ask the patient to sit up straight with open hand, you will see that there is increase in the carrying angle, right? And you look at the nails, the fingernails are small or hypoplastic with sometimes it is hyperconvex, and the fourth metacarpal is very, very short. And most of the children, people with Turner syndrome has is gonadal dysgenesis, so they are not fertile and they don't have normal menstruation, but some of them do have normal menstruation and can give birth, okay, can become pregnant and give birth, but the majority do not majority have gonadal dysgenesis, okay, right? So this is Turner syndrome. Okay, then I want to move on to birth defects, okay. Earlier I just want to I focus on dysmorphic and syndromes. Now birth defect. Actually dysmorphic and syndromes falls under the category of birth defect as well. Okay. Okay. So when I say birth defect, what does it mean? First, we have to understand the pathogenesis of birth defect. Okay. How does birth defect occurs? Okay, birth defect simply means that there is anomalies that originated from the fetal life, okay, intrauterine episodes, life periods, okay. So how does that happen? So we can divide that into four pathogenesis: malformation, deformation, disruption, and dysplasia. So what is malformation? Also known as anomalies or primary defects. It is a primary defect where there is basic alteration in the normal developmental process of a structure of the fetus, and this is usually occurring by 8 to 10 weeks of gestational age. Okay, in other words, the tissue does not form normally from beginning. Okay, an example of these anomalies are cleft palate, anophthalmia, ear atresia, like you see in the father and child with Treacher-Collins earlier on. ventricular septal defect. Okay, so but just to remind you, cleft palate or lip may not just be due to anomalies. It can also be due to disruption, okay, or deformation, okay. It can occur because of that, okay, right. And then we talk about deformations, okay. Deformation is alteration in the shape or position of the previously normal form fetal structure. For example, the hand has already developed normally, but because of there is generalized intrauterine compression or biochemical forces that mold that part of the tissue over a prolonged period of times, did that part of the tissue become deformed. For example, the foot and hand which has developed normally, if it is compressed over a long period of time, it can become contracted and deformed, okay. I'll give you an example. Here is a situation where you see that the hand and the foot of this child are deformed, isn't it? Into these structures. That's because in this child, the mother has low amniotic fluids, okay? So in other words, in the uterus, the spaces are very restricted because of the low amniotic fluid. Okay, the child is positioned in that position over a long period. He can't move because there's not enough amniotic fluid, and eventually he is born deformed like this. Okay, and this can happen because the mother, the child has oligohydramnios, or there is other factors like small pelvis, or maybe there is a tissue tumor in the uterus, such as presence of fibroids, for example, right. Okay, so this is deformation. Okay, now we talk about disruption. Disruption is when there is destruction of the tissue that has previously developed normally. For example, in this example, you see this is the fetus, this is the amniotic membrane, which has ruptured in utero, forming bands. And during the fetal life, this band form constriction around the structures of the baby, to the extent that these structures become ischemic. So because of this ischemia, some part of the limbs will be amputated, will be necrotic or gangrenous, and eventually amputated, like in this example in the hand. So part of the fingers has already been amputated, okay, because of the ischemia. But others are just there are evidence of constriction bands, okay. So this is what we call as constriction bands syndromes, okay. Other causes of disruption includes infection. For example, if the mother has chicken pox in the third trimester, the infection, the varicella virus, can attack the fetus and destroy, causing some destructions and deformations, okay. Dysplasia is a bit different. Here what happened is that is the tissue, that the structure of the tissue, cells of a tissue did not develop normally. Okay, for example, in these cases, a group of people with achondroplasia, so what happened is that they are, if you look at them, they are short, they have very short limbs, okay. And what happened is that the bone, the cell structure of the bone of the gross cartilage is not normal. So in that resulted in the bone to not being able to grow normally, okay, right. So you call it this as skeletal dysplasia, okay. And birth defect, you can classify birth defects major or minor. Major if it is severe, it impaired normal body function. It potentially has long-term medical, social, or psychological implication, and normally it requires surgical intervention. Otherwise, it is not compatible with healthy health of the child. Okay, minor if it is primarily of cosmetic significance, such as having an ear tag, having a small ear, having clinodactyly, having polydactyly, and it normally requires no treatment. It can be corrected and it's easily corrected, unlike the major defect where it is not as easy to be surgically repaired. And the minor birth defect has variable frequencies in the normal population. If you look at your friends, you might see that some of your friends ada setengah tu ada ear tag, ada ear pit, which is normal, right? But this is still a form of defect, but it's a minor birth defect. However, having a minor birth defect doesn't mean that you shouldn't take things seriously, because having a single minor anomalies has been shown to be associated with major anomalies in 3% of patients, and having two minor anomalies has been associated with 11% with major anomaly in 11% of the individual. Okay, and having three or more is in 90% of people having three or more minor anomalies will have a major anomalies. Okay. Okay. Another way of classifying birth defect is whether it is isolated, a sequence, association, or syndrome. We have talked about syndrome just now. So this is the same syndrome that we are talking about. But otherwise, there are a group of people with isolated birth defect. It means that one birth defect, that's the only defect that he has. For example, somebody might have ventricular septal defect, but that's the only problem. Okay, so this is isolated birth defect. Okay, or sequence. A sequence is if you have one abnormalities, but this one abnormalities lead to other anomalies. Okay, so you call it a sequence. Let's have a look at the example. Okay, so this is Porter syndrome, Porter sequence. Okay, not really syndromes. Okay, so what happened in this child? Initially, there is primary malformation of the kidneys. There is renal agenesis, or other kidney disorders such as multicystic dysplastic kidney. And because of that, the fetus cannot excrete urine normally. So there is reduced fetal urine excretion leading to oligohydramnios. Okay. So because of the oligohydramnios, we talked earlier, the intrauterine space become very limited. The child is not able to move. The child is being compressed. Okay. And because of that, patients are born with specific faces. They have low set ears, they have big nose, prominent epicantic hole, and down slant to the eyes. And because the lung cannot expand normally during causing respiratory failure, cannot expand, so lung is not able to form normally. So there is lung hypoplasia. Okay. And again, there is limb deformities. Okay. Another example is Pierre-Robert sequence. Normally, during fetal development, the jaw, which is initially small, will grow anteriorly to the front. When it grows to the front, it will pull the tongue down. Okay. And when it pulls the tongue down, the tongue is initially located in your palatal regions. Okay. When it pulls the tongue down, so your palatal shaft can grow and move in the midline to the midline and subsequently close the palate. But if the tongue remain in that position, the palate will not be able to be closed, and hence the patient will have cleft palate. So this is Pierre-Robert sequence. Association is another situation whereby a patient is found to have certain congenital anomalies, but it is difficult to predict that it has originated from one source or from a unified etiology. So you call it association. An example is vectorial association, where there is vertebral anomalies, anal atresia, tracheoesophageal fistula, a cardiac defect, renal anomalies, and limb deformities. There is a wrong spelling. There's no Y. Sorry, silap. Okay, maybe I correct it now. Okay. Okay. So that is vectorial association. So there's a lot of children with this vectorial association, and a lot of studies has been done, and people cannot find a cause for it to explain all these anomalies. Okay, so you call it association. Okay, and syndrome, as we have thought about earlier on. Okay, but I just want to highlight that the etiology of syndrome is not just genetic abnormalities. It can also be due to teratogen, for example, infection, congenital rubella syndromes, or alcohol, fetal alcohol syndromes, or drugs such as anti-epileptic, fetal valproate syndromes. Okay, or it can be due to polygenic cause or unknown cause. Okay, okay. Okay, I just want to skip this. Okay, this one also. Okay, let me. Sorry, is repetitive. Okay. Let me move on to pedigree analysis. Right. A pedigree. What is a pedigree? A pedigree is a genetic representation of a family tree that diagrams the inheritance or trait of disease through several generations. Okay, so it shows the relationship between family members and indicate which individuals express or may silently carry the trait in question. Okay, so that is pedigree. So contohnya, if you look at this pedigree, okay, so you know the relationship in between 3 and 2 7. So, and then you see that within this family, who is affected and who is likely to be affected. And from this, you can figure out what is the likely mode of inheritance. Okay, and who are likely to be carrier, or maybe depending on the mode of inheritance, whether it is a carrier or whether the disease is will be fully expressed or not. Okay, so to draw a family pedigree, you need a minimum of 3 generation. Okay, so this is a minimum 3 generation, first, second, third. Okay, 3 generation. Okay, and you must use standardized symbols, which is proposed by the Pedigree Standardization Task Force from the National Society of Genetic Counselor, US. Although this is from US, but now this is taken as the standard symbols by most of the genetic association worldwide. Okay, and this is how it looks like. Okay, so if it is just for example, for normal female and male, okay, male, female, this is affected male, affected female. If the person in question has different diseases, so that is how you color it. But when you put this different symbol in the patient, you must put a legend lah. What does black mean? What does grey mean? What does this color mean? Okay, this is a symbol to indicate obligate carriers. I mean, they are carriers, they will not manifest the disease. Whereas this indicate that this is asymptomatic or pre-symptomatic carrier, meaning that pre-symptomatic meaning that they may develop the disease later on. Okay, or they may develop the disease when in certain situations. Okay. This slash indicates that the patient has died. If the symbol is drawn as a diamond-shaped structure like this, it means that the sex is unknown. For example, you ask the family history from a person, he said that he knows that he has 5 cousins from the auntie, but he don't know whether how many boys or girls. So you just draw a diamond shape to indicate 5%. Right. This arrow with a P at the end indicate that this is a proban. Cumanya dia sepatutnya reverse. Maybe I correct this. Okay, sorry. I'll just do a correction. It should be flipped. Okay. It should be like this, okay? Same thing here. Okay. Good. Okay. So this indicate this is the proband. Proband is a person within that family. Say we saw the family here. So this one is arrow without P means that consultoid means that sorry. It means that this is the person seeking your genetic consultation. So whereas a proband, okay, so I'll just show here, okay. So maybe the proband is this person. We put a P here. Is let's put. Okay lah. Right. So here is actually the person within the family. This is the first person who seeks consultation for this genetic condition. So he is the first person to be identified to have these genetic diseases within the family. So he is the proband. Okay. Okay. Right. And a straight line in between two individuals indicate marriage. So if the male and female is related by blood, there is a blood relationship. So they are consanguineous. So you draw a double line. If they are divorced, you just put a double slash there. Okay, and this is marriage with children. So in this case, 3 children, and here marriage without an offspring. So here, if there is an offspring without marriage, okay, and if you see that within a circle there is a number, so this indicates that there are 3 siblings, okay, three unaffected female sibling. For example, if there is 3 here, it means that there are after the third daughter there is another 2 daughter. All of them are not affected. Okay. And for twin, this is the symbol. So if it is identical twin, it is like this. If twin, but you're not certain whether there are monozygotes or dizygotes, then you just put a question mark there. Okay, right. And if this is adoption, it's like this. If the lady is pregnant and the fetus is not known, the sex of the fetus is not known, you just put a diamond there with the word P in the center. If it is a male, you put a male symbol with P. Stillbirth, it is like this. Spontaneous abortion, it is like this. This is termination of the pregnancy, okay? And if you have examined the patient personally, you put a dash on top, okay? Right. Okay. Okay, you can read about this. I will share you these slides, the slides of this pedigree, so you can read and memorize or keep it for your use. Okay. Now I want to talk about mode of inheritance. Okay, so I think you have learned about mode of inheritance previously. Okay, now what I want you to do is to sort of figure out what could be the mode of inheritance of the pedigrees that I'm going to show you. Okay, right. Okay, Amelia Tan, are you there now or still in the toilet? Hello?
Hello, can you hear me?
Sorry?
Can you hear me? Hello, doctor, can you hear me?
Yeah. Okay, okay. So can you tell me what do you think? But before that, I think have you learned about mode of inheritance in your year 1 or year 2?
I think we have learned.
Learn tapi sikit-sikit lah.
Ah,
Okay, tak apa, we go through this and probably after this you will get better understanding. But okay, tell me what do you see in this family?
there's two children that have abnormalities.
Okay. Yeah. So is these two children any other people with these anomalies? Disease lah rather than anomalies, disease. With the disease?
No, maybe they are
No.
just carrier.
No, bukan. We don't know.
Okay.
But so the rest of the families are not affected by the disease. So and so is it affecting both male and female?
Yes.
So okay, so you see that two siblings are affected. It's affecting both female and male. Okay, so is it likely to be a genetic inherited disease or not?
No, because there are no history for the two upper generation.
But then how come a two sibling is affected? If two siblings are affected, then is it likely to be a genetic disease or not? I mean, we sort of we have ruled out infections or poisons or environmental exposure to something.
Yes, it is likely.
It is likely kan, this is a genetic disorders. So if it is a genetic disorder, where does it come from?
Yeah, maybe it's from the parents, but the parents is only carrier.
That's one possibility. So it means that it comes from the parents. If it comes from the parent transmitted to the children, it means that this is inherited disorder, isn't it? So if it is inherited disorder, father and mother could be a carrier. What could be the probably the mode of inheritance? Is it autosomal dominant, autosomal recessive, X-linked, recessive, X-linked dominant?
Autosomal recessive.
Most likely this is autosomal recessive lah. So normally, so just want to point that autosomal recessive normally is characterized by the disease affect both male and female. Okay, and there might not be any people being affected in the previous generation. It is a horizontal transmission, meaning that it doesn't come down from one generation to the second generation to the third generation. In fact, it is within the same generation. This is horizontal transmission. Okay. Then the sometimes you get that the parents to be consanguineous, but that is not always necessary. Okay. So this is autosomal recessive. Then we look at this figure. Okay. So okay, say I just say that this is a genetic disease. So because we have found that we do genome say we have done whole genome sequencing and we found that there is a genetic defect. So you look at this pedigree. Do you think this genetic defect is due to which inheritance based on this finding?
X-linked recessive or autosomal recessive.
That's two different things. Why not I ask okay, Anis Atikah ada dua tu. How come Anis Atikah ada dua? Is it two different person or same person?
Same person, doctor, two device.
So same person, that means how many people are supposed to be joining the class?
38, 37, including you, 38.
37. So that means there are 35 people sahajalah because there's 2 you here. So 2 person are not around. May I know who is the 2 person? Can the group leader find out? And but tak apa, he has to give the information to me why he's not present in the class. Another person? So I need a report. Okay. Right. Okay. Fadlan dah tanya Farhanah Akhtar. So okay. So you look at this. Okay, pedigree. Okay, tell me what you see. I know that you tak ada belajar sangat, tapi we'll start with this. Tell me what you see first.
There is birth defect in the 4th generation.
Dari apa? Birth defect. Bukan birth defect. Mana ada birth defect? Kita tak cakap. You wouldn't know what is this. Tadi a solid rounded structure. What does this mean?
Female is affected.
Okay, one female is affected by a disease kan? Bukan
Yes.
anomaly kan? Kita tak tahu anomaly
Yeah.
disease kan? Okay. Right. So then what else do you see? Sorry, Amina.
All of the male are not affected.
Yalah, maksud only one person in the family is affected.
Yes.
Kita tak tahu male ke boleh affected ke tak sebab it's only this female that is affected kan?
Yes.
Okay. Right. What else do you see in the family?
Ada ni divorce.
Apa dia?
I
What?
think ada simbol consanguineous marriage.
So who siapa simbol kat mana tu? Kat siapa tu?
In the 3rd generation,
Who?
the parents of the affected female.
So the parents are consanguineous. The female has a consanguineous parents kan? Okay.
Yes.
Right. Okay. So what do you think? Tadi saya mention kan, we have done whole genome sequencing and we found that there is a genetic variation in both alleles. Right. So what do you think is the mode of inheritance of this genetic defect, which probably is the cause of the disease in this child?
I think it's still autosomal recessive.
Okay. So, okay, that's correct. So again, as I mentioned earlier, if you see that there is no other family members affected and suddenly one of the person has a genetic disease and then you note that the parents is consanguineous, then the most likely mode of inheritance is likely to be autosomal recessive. Okay. Right. So here the important point is the presence of consanguinity in the parents. Okay. Right. And what about here? So naik kita cari orang lain. Hamzah.
Doctor, I have a question.
Yes.
Yang slide tadi tu, why adik-beradik dia kita tak put as carrier, memang tak ada langsung ke?
Bukan. Maksudnya clinically dia are normal. Lepas tu untuk tahu dia carrier ke tak, you kena buat genetic study dulu. Kita tak buat lagi lah ni. So kalau macam ni, you don't know lah whether they are carrier or not carrier. But
Okay, thank you doctor.
So what we know is they are not affected by the disease. Tu je. Okay. Now mana tadi? Dah bagi answer. Okay, Hamzah.
Yes, doctor.
Okay. What do you see?
In the 1st generation, the female is affected. and then it passed to the second generation for both female and male.
Okay. Good.
The third generation, it passed to the third generation too.
Okay, both male and female. So what sort of transmission is it? Horizontal or vertical?
Vertical.
Vertical transmission. What mode of inheritance?
Is it autosomal dominant?
This is autosomal dominant. You see it affects both male and female, and it is present in all generation of the family members. Okay, and you can see that the father can pass the disease to son and daughter. The mother can pass the disease to son and daughter. So okay, so and right. Okay, so and it is vertical transmission. Okay, so this is characteristic of autosomal dominant. Okay, you see the difference in autosomal dominance and recessive. Will it differentiate? This is dominant, this is recessive. Ataupun this is recessive. Can you differentiate?
Yes.
Okay. Okay, now what do you think? Next person siapa? Iman Noah Rushdan.
Yeah, doctor.
So describe what you see.
I see an affected female in the first generation, and it's passed down vertically, affecting females and males in the second and third generation.
Okay. And the mother transmit the disease to who?
Son and daughter.
Okay, and the mother transmit the disease to?
The mother transmit the disease to son and daughter.
Mother transmit the disease to son and daughter, and the father?
The father doesn't transmit disease to anyone.
So what do you think is the mode of inheritance in this?
I think it's X-linked recessive code.
Kalau X-linked, that means the mother is a carrier kan? Is a carrier. So because one X carry the disease gene and the other X do not carry the disease gene. Kalau macam tu, do you think the mother will be affected kalau recessive?
Oh, tak boleh lah. Betul lah. So, it has to be X-linked dominant lah.
Kalau dominant, that means mother will be affected lah. Tapi will all the male child will be affected or not?
All the male child will be affected.
Tapi in this case, adakah all male child affected?
Yes.
No, ni grandmother. Lepas tu, okay, ya betul. Okay, all male child affected. All male child affected, okay. And then, what about the male affected child? Will it transmit the disease to the daughter and son?
No, it won't.
Kalau affected male.
Kalau affected male, the daughters akan dapat, the son takkan dapat.
Tapi in this case, daughter semua tak kena kan?
Affected male, daughter tak kena.
So here semua daughter tak ada kan? So kalau X-linked dominant, the male will transmit the disease to all daughters kan?
Correct. So it's recessive macam saya kira tadi.
Recessive tak boleh lah. Female affected.
Kalau X-linked recessive, saya dah confused lah. Kalau X-linked recessive,
the female will not be affected kan?
Oh yeah.
So it cannot be X-linked lah. Both correct. X-linked recessive pun tak correct. X-linked dominant pun dominant is incorrect. What about autosomal dominant? Is it possible?
Autosomal dominance. No,
Why?
because no, actually, yeah, it is possible.
It's possible because autosomal dominant, if you are having the disease, the chances to for you to transmit the disease to a fetus is only 50% kan?
Mm-mm.
There is only a 50% risk for each child to be affected. So that is possible. What is the other possibility? Mm.
The mitochondrial inheritance.
Mitochondrial inheritance is also a possibility. So ada dua possibility dah kan. Satu mitochondrial inheritance, satu lagi is possible juga autosomal dominant kan. Okay. Then what? Okay, next. Okay, so everybody clear ke tu? Tapi you get some taste, some feels about this inheritance so that in the future you can sort of try to figure out. Okay, Jazlyn.
Yes, doctor.
Tell me what you see.
So first the male is affected and then it passed to the second generation, both male and female is affected.
Mm-hmm.
And then the third generation, male and female also affected, same goes to the fourth generation.
So this is vertical transmission kan?
Yes.
Transmission affecting the, you tak payah cerita first generation male, second generation.
Oh, okay.
Just say that in the family the disease affect the male and female.
Female. Oh, okay. Okay, doctor.
The male can transmit the disease to the daughter and son, and the son can transmit the disease to daughter and son juga. So what mode of inheritance is this?
Is it autosomal dominant?
Okay, reason vertical transmission affecting male and female. Okay, it is passed from father to son and daughter, and from mother to son and daughter as well. So this is autosomal dominant. Okay, now what about this? Siapa pula next? Okay, sekejap. My Sarah.
Yes, doctor.
So tell me what you see.
I see that at the second generation, the male is affected.
Kejap. Tadi saya dah cakap, tak payah sebut second generation. So, in the family, who is affected? Male or female ataupun macam mana?
I can see the male affected.
So you can say that can you say that in the family?
In the family, the male is affected.
Only the males are affected kan? Only the males are affected. So it runs vertically juga in the generation. Okay, lagi? What else do you see? Does the male transmit the disease to their children?
No.
No. So in the third generation, who do you think the disease comes from? Is it from the father or from the mother?
I think from the mother.
Mm-hmm. So okay, so it seems like the disease is transmitted from the mother to son, kan? And the mother is normal phenotypically. So the mother is likely to be a carrier. Kan? So what is the likely mode of inheritance?
X-linked recessive.
X-linked recessive. Okay, yes, correct. So this is X-linked recessive. So you see that the disease is transmitted from the grandmother to the mother in this small pedigree here, and this mother, and it affects the son, but the son do not transmit the disease to their offspring, but the mother transmit the disease to the son. So the daughter, we don't know whether they are carriers or not. Okay. So this is X-linked recessive. And what about this? Kejap, I think sorry, yang ni ada silap ni, tak apa tak apa. We skip this one, tak ingat buang. Okay, better remove this. Okay. Okay. Right, just remove this one. Delete slide. Okay. Okay, what do you think? Okay, sorry. Yang ni pun ada kesilapan juga ni. Okay, we slip this slide. Okay. Okay. So in this case, what do you think is the mode of inheritance? Apa nak jawab? Kena panggil ya. Siapa tadi ya? We go from bawah pula. Wei Hua.
In the family, both the female and the male offspring are affected, and there are the horizontal transmission, so there could be autosomal recessive.
And no other family members affected kan? Okay.
Yeah.
So, but there are various possibility I put there, but most likely is autosomal recessive. Okay. You answer autosomal recessive, you got full mark already lah. Okay. Okay. Never mind. We forgot about the rest. Okay. And what about this? Okay. Sorry. Okay. Hang on. Right. Okay. So, okay. I think this is just to highlight the variation that you will see in this mode of inheritance. So what you see here, you see that male and female are affected. It seems like this disease in the third generation is likely to come from the mother, kan? Who do not manifest the disease, okay? And it could have come from the grandfather or the grandmother. Okay, so what is the likely mode of inheritance in this case? Sorry, hang on. Hello. Hello. Duk mengajar. Okay, insyaAllah. Okay. Okay, so okay. Wan Nur Amalin.
Okay, in this family, both male and female affected, and then it is inherited vertically, so probably it is X-linked recessive.
X-linked recessive, tapi why one female affected eh?
Oh, sekejap. Is it X-linked dominant?
X-linked dominant tak boleh lah kan? Kalau X-linked dominant, all daughters of an affected male will be affected kan?
Oh, okay. So autosomal recessive.
You tak boleh main teka-teka bubuh semua tu.
Tak pasti, doktor.
Okay, cumanya what you notice is that the majority are males, only one female is affected, kan? But the rest of the females are not affected. Cumanya it is likely that the mother of this family is the carrier of the disease, okay? And she did not manifest the disease. So one possibility is that this is X-linked recessive with this person. Nampak arrow saya tunjuk lah?
Nampak.
Is affected because of lionization. Okay, so the other possibility is mitochondrial inheritance lah. Okay, so right. So because mitochondrial inheritance, itu yang saya nak mention variation ya. depends on the number of mitochondria that is affected. So dalam you punya cell, say you got 100,000 mitochondria, if only 10,000 is disease and the other 90,000 is normal, so you will probably not manifest the disease. But if in your cell, say that 70% of your mitochondria is disease, only 30% is affected, then you will manifest the disease. So in this particular case, the mother might have disease mitochondria but not reaching the percentage enough to result in disease. Okay, but she transmit it to the sibling, to the son. But I think the more possible diagnosis is X-linked recessive with lionization. Okay, so you remember lionization or not? What is lionization? Sekejap. Siapa nama dia? Ameline, do you remember what lionization?
Lionization, is it X inactivation?
Correct.
Okay.
So biasanya kita ada female ada 2 X chromosome kan? But those 2 X chromosome, only one is active because one is being inactivated. That is normal lah for all females. Okay. Cumanya if you have 1 X chromosome which is normal and one X chromosome that is being inactivated, most of the time random inactivation will result in 50% of the disease X chromosome will be inactivated and 50% of the non-disease X chromosome to be inactivated. So in other words, you have the activated chromosome to 50% is still is normal. So the patient will not manifest the disease. Tapi katalah lionization occurs resulting in say the majority, say 60% of the normal, 70% of the normal chromosome is being inactivated, and so the activated chromosome X is majority is the disease one. So the patient will manifest the disease, kan?
Betul.
Okay. So that is lionization. Okay. Right. Okay. I think one last one. Okay. This one siapa nama atas? Ainul Basirah.
Saya doktor.
So what do you see here?
Both male and female are affected.
Okay, good. Yeah.
The female can give the disease to both son and daughter, and the affected male can give to the daughter. The affected female give to the son and daughter.
So
is it X-linked dominant?
Okay, so possible or not? Kalau X-linked dominant, female ada satu X disease, satu X tak disease kan? X disease tu, she will give it to her son and daughter, 50-50 lah. Okay, right. So there are sons and daughter who will not be affected by the disease. Okay, so that compatible kan? But male will give the disease to all the daughters but not son kan? And okay, so that is possible kan? Actually dominant. So this is actually dominant. Okay. Okay, you dah tengok semua example kan? So you got the rough idea kan how you determine the mode of inheritance and what do you mean by mode of inheritance? What do you mean by that? Okay. Okay, we'll skip the others. Okay. Okay, that. Right. So that is pedigree. I want to go to touch on genetic counseling, because this is one of the things that you do in the genetic clinic. So what is actually genetic counseling? Genetic counseling is not the normal counseling that you give to a person or individual or families because of social issues or whatever, or psychological problem is different, but it is still a communication process in which you aim to help and individuals, couples, and families to understand and adapt to the medical, psychological, familial, and reproductive implication of the genetic contribution to a specific health condition. Okay, right. Implication of this genetic disease. To say in layman's word, what I said just now is the definition given by the Human Genetic Society of Australia. Okay, but in layman's term, you were trying to help them to give them information to when a family is known to have a specific genetic disorders. And then at the same time, you give them information about the condition, and then you explore the personal consequence of this information. Then this is to help the families at risk to make informed reproductive decision. Okay, say the mother is a carrier of an X-linked condition, serious X-linked condition. So she has one son who is affected. Now you give genetic counseling so that they can make an informed decision of what they want to do. Do they want to have another child and take the risk, or they want to opt for other alternative? Okay, right. So how do you do genetic counseling? It's like any other clerking of any other case. You take history, you do clinical examination, but you conduct and you construct an extended family pedigree, and then you do you ask for specific genetic testing, appropriate laboratory testing, not just genetic. And then you interpret the family and medical history to assess the chance of disease occurrence or recurrence. Okay. So again, this is just but apart from education about the natural history of the condition and the inheritance pattern, and what sort of testing can be offered, and how to manage and how to prevent the disease, you also provide them information what are the available resources to support them, and also you discuss with them the ongoing researches related to the disease. Okay, because most of these genetic disorders are quite severe diseases that is disabling, devastating, expensive to care, and with the potential of recurrence in the future generations. Okay, so you have by informing about the ongoing researches that give a lot of hopes to the family. Maybe this will not help their daughters or son, but it will help to the future generations. Okay, and also by informing them about the research, it would sort of stimulate them to participate in the research and help to help develop treatments or whatever things that will improve or benefits their families. Okay, and then you counsel them with regards to risk assessment. Just now, as I have mentioned, for example, if a child has cleft palate, okay, you look at this table. If, for example, both parents are affected and the child has no siblings at this point of time, first child, for example, ataupun has two siblings but all other siblings are unaffected, so the current child say the mom is pregnant, there is a 35.4% risk possibilities that the child the fetus is affected. Okay, right. But if say that she has they already have one child who is affected, then where is it? Okay, I just want to two siblings. Okay, two siblings affected. Okay, never mind lah. Just take any example. Okay, so if the one one maternal auntie is affected, then the risk is higher, okay, for the fetus to be affected, 40.8%, okay, right, okay. So this is the sort of information that you give to the families, okay. Okay. So again, I just want to stress, genetic counseling is not primarily counseling in the psychological sense. Although there are a lot of psychological component during the counseling session. And most important, it is non-directive. You aims to give fact as clear as possible, as accurate as possible, so that they can decide on their own what they want to do, okay, particularly in the with regards to reproductions, okay. So non-directive means that you don't tell them what to do, okay. You don't say that you must not have any other child. That's not how you do, okay. It is up to the family to decide. Or you wouldn't say you have to terminate the child. No, you wouldn't do that. You give information and let them decide. Okay. Okay, I will skip that. I just want to talk about this direct to consumer genetic testing. Nowadays, you see lots of advertisement saying that you can just send blood samples and the company will give you information about your health, okay? Your chances of having cancers, dementia, or other disorders. So what you need to do is you just send your saliva or you send a blood spot to the companies and they will give you information. So this is known as direct to consumer genetic testing, okay? This actually, it is not really acceptable because of various issues. First thing first, say if your mother opted to do this, so she spent like 2009 $2,090 ringgit Malaysia to check her house. Then she got the results, but she do not have any specific doctors to sort advice. Okay, this is not really very ethical, huh? Right? And to give the correct information, what does the genetic test mean? Okay, so this direct to consumer genetic testing is not really acceptable in many countries, but it is mushrooming in all over the world. Huh? Okay, right. Okay, with that, I'd like to stop. But before that, we just go back to our key point, learning key point. Okay, just where is it? Okay, desktop. Okay, right. Okay. It's jam. Okay, never mind. Okay. So we have covered a type of genetic abnormalities, type of genetic disease, including birth defect, a mode of inheritance, family pedigree, genetic counseling. Clinical genetic service, I think we should stop now because it's already 12 o'clock. But maybe during year 5, I will talk about it again. Okay, for this time, we do not proceed to this section. Okay, do you have any question? Uh-huh. Yeah. I think at this point of time, the standards is katalah depend on who you are. Are you supposed to be masa tu clinical geneticist ke ataupun you are a medical officer? Depend on who you are juga. Katalah you are masa tu medical officer baru habis houseman kan, dekat dengan di one of the KK. Okay? So masa tu you will say that this test is, I mean, you can't stop them from doing, but it is not advisable. Because if you want to really seek information about potential of having a disease, then you should see a proper specialist in the field. Okay, either you refer to a clinical geneticist or you refer to a genetic counselor. Okay, for first, so let them advise the patients whether they should proceed with it or not, and also what actually that they want to find out. What does the patient want to know from the test? Okay. Do they just want to scan themselves to see whether they are having potential to have any disease? But before that, they need to be prepared. What if they send the test and they found out that they are high risk of developing dementia at the age of 50? Are they ready to receive the information? Right. Okay. Does that answer your question? Okay. Any more question? Okay. Kalau tak ada, kita stop lah sebab saya pun kena buat round dulu. Terlebih panjang sikit lecture ni. Okay, but I will send you the pedigree tu, contoh pedigree tu. Cumanya group posting yang last posting pun saya lupa nak bagi. You all sekarang berapa? 2 minggu sekali ke? Tukar. Patutlah saya rasa macam tiap minggu nak bagi lecture. Okay. Alright ya. Okay, so I hope you manage to learn something from the lecture. If you have any question, just WhatsApp me. I will try to answer. Okay. Alright. Assalamualaikum.
Thank you,
Doctor.
Thank you, Doctor.